Welcome to today's talk titled Sex, Gender, and Policy, How Policy Impacts Sexual and Gender Minority Health with Dr. Carl G. Streed Jr. I'm going to give a brief introduction to Dr. Streed. Dr. Streed is an assistant professor in the Boston University School of Medicine. After attending medical school and residency in internal medicine at Johns Hopkins, he completed fellowship in general internal medicine at Brigham Women's. Nationally, he has chaired the American Medical Association Advisory Committee on LGBTQ Issues and served on the board of GLMA, Health Professionals Advancing LGBTQ Equality. Carl's efforts to improve the health and well-being of sexual and gender minority individuals and communities have earned him several awards, notably from the University of Chicago Alumni Association, Johns Hopkins University Alumni Association, the American Medical Association Foundation, and the World Professional Association for Transgender Health, as well as recognition from the Obama White House. As a research lead for the Center for Transgender Medicine and Surgery at Boston Medical Center, he collaborates with researchers, physicians, and staff to assess and address the health and well-being of transgender and gender diverse individuals. So we are very grateful for your time and for you being here with us today. And I'm going to hand it over to you, Dr. Streed.
Great, thanks for having me. I just make sure you can hear me, correct? Yes, good,
yes.
Okay. Please, I naturally, given the nature of us doing this remotely, I can't see questions as they come into the chat immediately. So please feel free to interject. Dr. Norwood, if you see anything in the chat that needs to be answered immediately. I'm aiming to try and leave enough time at the end for about 10 minutes of Q&A, which means I'm going to be talking very quickly, which is kind of my natural habit since I'm not a big fan of giving talks since I'm such an introvert, but I think this is an important topic and I appreciate the invite. I'm going to be covering very broad swaths of the ideas of how policy affects minority health, particularly sexual and gender minority individuals. I have no significant disclosures as it relates to this other than this is my career, as it were. I like to give a land acknowledgement. I'm based in Boston, which is essentially the original lands of a number of tribes, including the Massachusetts tribe. And I think the first step in addressing an issue is at least acknowledging it, that we are on occupied lands. Objectives, these are the broad objectives. We're going to talk about policy effects. I'm going to review some existing policies, and I'll talk about opportunities to actually improve them and potential ways that you can do that at the local and national level. Before I do that, I naturally just like to have a baseline of the basics of terminology. This is the National Institutes of Health Sexual and Gender Minority Research Office definition for SGM. And I think everybody has a good idea of this. This is essentially, it covers lesbian, gay, bisexual, and trans, but also all other identities that have often been neglected from the LGBTQ acronym, as well as anything that might fall outside of the binary or heterosexist or cisgendered notions within our society. So I always like this last sentence where they say these populations also encompass those who do not self-identify with one of these terms and also have a sexual orientation, gender identity, expression, or reproductive development that is characterized by non-binary constructs. So again, very broad categories that we're talking about here. I also like this kind of graphic because it really moves us away from thinking of things in opposition and rather that you can have a combination of any component of these issues. So we'll dive into these very briefly. We'll have access to the slides. We'll have a recording. You can pause me if you need to read through these. But I mean, the basics, of course, people understand sexual orientation essentially is the type of attraction, physical, romantic, or sexual that you may feel for somebody. We try to really avoid the term sexual preference. I don't think it's an appropriate term, and I know it's definitely has come up a few times. I actually read it more as a dog whistle for people who intend to do harm. But that being said, it is outdated, and I try to give people the benefit of the doubt if you hear sexual preference in place of sexual orientation. Big part of being a clinician is understanding that just because you know somebody's sexual identity or their sexual orientation doesn't mean you know their behavior or vice versa. So it's also important to know that just because you know it at this moment in time doesn't mean you're going to know what a person's sexual orientation or behavior is going to be in a decade or down the road. So recognizing that these are things that change and are dynamic over the life course. And I think these kind of graphics really just drive home the notion that these are just components of a person's sexual orientation. As it relates to gender, I like to talk about gender identity as really just your internal sense of self, your understanding of who you are as it relates to our social construct of gender. Expression is how we use social and cultural cues to really express our gender, to let people understand what our gender identity is. And these are all socially and culturally derived. I think it's important to recognize that some cultures may describe one thing as masculine and another culture may describe the same thing as feminine. So recognizing that it's really important to understand the context. And the larger component here, I think, is really how these are nested within one another. I think sex assigned at birth is the term that we are, or the concept that we're taught most often within clinical settings, the idea that it's male, female, and that's it. We know that it is not that straightforward. And we know, in fact, that there are a number of other identities as it relates to sex assigned at birth as well, notably intersex or differences in sex development. So I think it's important to really recognize that none of the concepts are what we were taught they were. And I think it's important to really see how these are nested. I think as it relates to policy, the outer layer, perceived gender, is really important because people are interacting with you based on what their perception is, not necessarily what your actual gender identity or even sex assigned at birth might be. It's what they perceive your gender to be is how they're interacting. So I think, and this is where the level of interpersonal and policy level interactions happen. Slide of definitions. You can check these later, essentially all the stuff that I've covered at this point. I think it's important to recognize when we talk about the effects of policy, who's being affected, how many people are being affected. So I always get a kick out of this Gallup poll, which has been surveying Americans for quite some time. And you can see the trend that apparently in 2015, a large number of Americans thought about 23% of the US population was lesbian or gay. I always get a kick out of this because I never know which neighborhood that they live in. And I'm just like, where's that neighborhood? I want to live there. But we know the reality is a little bit closer to about 4.1%. We know that percentage is actually higher among younger populations as well. So here you see ages 18 to 36, that 7.3% of individuals identify as LGBT. We also see, of course, that there are disparities across across LGBT categories as well as it relates to household income. I like using this graphic again because to think about, you can think of these as individual little jurisdictions. This is the county level data for same-sex, same-gender households based on the 2010 census. Important thing to recognize big limitations of this. I'm talking about same-sex households. It's ignoring anything as it relates to gender identity, and it's erasing anybody in any bi individual in a opposite gender relationship. So again, recognizing that limitations to all the data we have. But this, I think, gives you at least a good overlay of saying we are everywhere in some way, and that every jurisdiction has the potential to affect their LGBTQ population. And I think it's helpful to really think about historically too where some people are ending up. So this is looking at African American same-sex households, again congregating in the historic South. Here we see Latin households, same-sex relationships, again, historically what was once all of Mexico. So recognizing the historical overlays as well as in terms of the geographic distribution of LGBTQ folks. Some great work is a reminder. I mean, just recently the census got closed earlier than it should have been, essentially as an opportunity, as a power grab by this administration and their stakeholders. So recognizing that the census and other opportunities to provide data are really important in terms of making sure we understand what's going on for LGBTQ individuals. I also want to point out some differences because you'll note policies change over time and those effects may really lead to differences across generations. The generation study done by folks at the Williams Institute really highlights some key findings here. So you see, this is looking at LGBT individuals. And you can see that across generations, and they broke it into three age categories, 18 to 25, 34 to 41, 52 to 59. You can see that everybody across generations is recognizing their same-sex attraction around the same age, 11 to 12. But then it's when you start spreading out in terms of actually having sexual debut or identifying even as LGBT, and then of course coming out to a family member, gets very much spread out across the generations. And that I would say is probably a marker of the general climate for those folks. Which is why I always like to say this is an indication that it's not that more people are becoming LGBT, it's that society is becoming more welcoming to where the true, the number of people who can safely and comfortably come out is increasing. So this is not something that we're causing, it is something that we are allowing people to finally fully express themselves is the way I think of it. Similar work is being done as it relates to transgender health. Research findings from this similar study are forthcoming, and I'm optimistic that we'll see similar results as a more accepting society evolves. We will see more people who identify as such. That said, want to highlight again what are the numbers that we know as it relates to trans-identified individuals. This is great work done by Kellen Baker, who also has been doing great work on the national scene for data collection for many years. Highlighting that about 0.5% to 0.6% of US adults 18 and up identify as trans within a national survey. This is the Behavioral Risk Factor Surveillance System. And of course, we know there's significant geographic diversity about where people may identify or where the prevalence of trans folks may exist in the US. But skipping that, there are opportunities within state level data to really highlight. This is my own city, this is Boston, and I live in the very dark purple JP, Jamaica Plain, where again, recognizing that localities and the policies of localities can affect different populations in unique ways. So I think this kind of data is really important, and honestly, a lot of this kind of data exists for different states as well. I do want to provide a little bit of historical context because I think there is an overlay and this is not new. While there's been an explosion of LGBTQ-focused research, SGM research, in the past decade, and it's been going on for many decades before that, it really has been going on for even longer than that. This is Dr. Magnus Hirschfeld, who had founded the Institute of Sex, or what's translated as the Institute of Sex Research in 1919, was one of the earlier proponents of affirming gender identity, really trying to understand gender identity and not treating it as a pathology, but as something to really be expanded within society. Unfortunately, Dr. Hirschfeld, being based at that time in Germany, his institute was destroyed by the Nazis at that time, and much of his work was lost as well. And unfortunately, this was probably the high point at that time of affirmative research and care as it relates to sexual and gender identity, because then we know, of course, that medicine kind of went the other direction, recognizing that there were these identities and that initially it was affirming, started to treat them in a pathologic way. We know specifically as it relates to conversion therapy, this was a major issue in the late 19th century, late 1900s, late 19th century, late 1800s, and moving into the early 1900s as well, and really kind of peaked around World War II. And the the APA also really supported this. So there were very defined ways of doing this in terms of aversion therapy. And we know that there actually are modern examples or modern portrayals of what this might have looked like in real time, including American Horror Story, which actually demonstrated aversion therapy as related to electroconvulsive therapy and chemical aversion as well. But we know that this is still going on in a number of enclaves. But thankfully, medicine, again, with good research, was able to sway opinion within these organizations, and then from there kind of branch out. Dr. Evelyn Hooker was one of the first to really highlight that maybe we should be looking at people without any kind of mental illness and see what's going on there instead of just focusing on this biased cohort, as it were. And her work, among many others, really led to changing the DSM in 1973 to remove at least homosexuality. We've continued since then to really address issues as it relates to gender identity within the DSM as well, moving away from disorder to dysphoria, and ideally, perhaps in the next iteration, really trying to remove it as a pathology altogether. I would point out that during this movement at this time in the US, that there was concurrent activism that was really trying to address policy. So here is Frank Kameny, Gay is Good, really trying to address issues as it relates to employment discrimination based on sexual identity. Frank Kameny was among many civil servants who were essentially lost their jobs within the government because the government was rooting out people they saw as deviant, including gay individuals. And then, of course, multiple issues as it related to police brutality and excessive policing or policing in general around sexual identity and gender identity, particularly as it relates to the Black Cat Bar, of course, the Compton cafeteria riots, and Stonewall. This is all happening in the same time, and honestly, we're kind of communicating to each other because this is kind of the discussion at the APA in the context of what was happening on the streets as well. I would be remiss if I didn't point out that one of my home institutions as well, Hopkins, had a long storied history of being affirming as it relates to gender identity, but then quickly reversed course when they had different leadership. And when they closed in '79, it adversely affected access to care across the US for many years to come after that. And thankfully there was what was called at that time the Harry Benjamin International Gender Dysphoria Association, which became WPATH, the World Professional Association for Transgender Health. And while the US shut down, the world marched on, and we definitely know that we are trying to catch up at this point. So now, kind of gave you terminology, a little bit of the historical context, whirlwind, as it were. And now I want to really talk about what's going on as it relates to policy and how is policy affecting individuals. I think it helps to really frame it within minority stress theory, which is the prevailing theory for how we think that multiple external stressors adversely affect health outcomes. And we call it minority stress because it's really rooted in minority identity. So you can recognize on the left of the slide, there's minority status, kind of whatever that minority status could be. This has been broadly applicable and well researched within racial and ethnic groups as well. But for this, in this case, Ilian Meyer and Dr. Brooks and others have really rooted this in sexual and gender identity. That identity status exists, and then you internalize it, you recognize it for yourself, and then this is how different stressors start impinging upon you. Distal stressors are the ones that we're more common with in terms of this is how society is responding to you, this is how your family is responding to you, this is how people respond to your identity or your perceived identities, I think it's important to point out. And then proximal stressors are how that gets internalized. Your internalized homophobia, transphobia, it's your hypervigilance that we have in certain situations where we're trying to predict or avoid negative consequences. And then all of that leads downstream to health outcomes. There's a lot of different theories about the ways in which it does that. For a long time, we thought it only had to do with, well, you're dealing with your stress with poor coping mechanisms by drinking and smoking more. While that does, in fact, impact your health outcomes, that alone doesn't account for a lot of the disparities we see in LGBTQ health. We're now beginning to understand that stress by itself adversely affects a number of pathways that lead to different health outcomes, particularly as my research focuses on is cardiovascular health, really noticing issues as it relates to inflammation, immune dysregulation, and the like that lead to eventual worse and earlier cardiovascular health disparities. So kind of summarize the minority stress theory. These slides are really more for you for later viewing, but again, this is kind of really highlight, this is how we try to frame a lot of research and a lot of policy effects for LGBTQ folks. So again, recognizing external stressors, distal stressors can be very high level structural. These are the policies, and this is what we'll talk about, but they can also be at your institution or your community institutions, your church, your community gathering places, and then of course, interpersonal, any interaction with an individual. But of course, as I mentioned, the proximal ones, and it's not just the internalized stuff, but this vigilance, this need to always be on guard definitely adversely affects folks. And here, again, multiple citations that will come up in the next few slides, the idea that experiencing different forms of discrimination, external stressors are associated with higher levels of depression, anxiety, suicidality. We know this effect is greater among persons of color and bisexual people who we believe are experiencing additional stressors from LGB communities as well, LG communities as well. Of course, gender-based discrimination not only affects cisgender individuals, but it's also affecting gender-diverse individuals. And then, of course, we see early on family rejection leads to increased odds of suicidality and suicide attempts among trans individuals. Multiple issues as it relates to specific discrimination based on sexual orientation leads to higher smoking and drinking among LGBT adults. Lifetime discrimination has been associated with a number of other issues in terms of illicit drug use, cannabis use, and then again, for trans folks, very similar trends in terms of increased smoking if they've been exposed to significant discrimination throughout their life. We are still trying to fill in the gaps as it relates to physical health. We are beginning to see more as it relates to certain policies, though. So, for example, Dr. Hetzenbuehler really highlighted that the legalization of same-sex marriage in Massachusetts actually led to a wonderful natural experiment where we could look at health before and after that change in policy. And we saw a significant reduction in hypertension among gay and bisexual men within that data. Again, we've seen issues as it relates to certain pathways, as I mentioned, this issue with dysregulation in the sympathetic nervous system that leads to certain cardiovascular issues, particularly hypertension. It's also been associated with diabetes. And then, of course, growing up in a stigmatizing environment, so a family that is rejecting or not supportive, has led to like a blunted cortisol response among youth. What this really means is that they're so hypervigilant that they're not really able to mount a sufficient stress response in some situations. And again, places where civil unions were enacted before they were a national, before they finally were addressed nationally. Those places, we noted lower depressive symptoms and alcohol use among lesbian women, trans people who, and again, multiple exposures as it relates to trans folks and substance use. I think the point here is this is early data. You can see from the citations, a lot of this was in the last decade. We still need better data to really expand on this and understand exactly what's going on, but we are seeing consistent trends that exposures to stress, discrimination, stigma, and even at the policy level, that these are affecting particular self-reported outcomes. So again, these are kind of the things we would think about in terms of what we should be doing better. And this is actually from an American Heart Association paper on LGBTQ health and cardiovascular health that really models the minority health into the existing evidence. So again, highlighting that identity leads to, that certain stressors attached to that identity can lead to certain behaviors or psychosocial factors, or what we're trying to better understand, actual physiological changes that lead to worse outcomes and risk. So this is all what we're trying to understand. The issue here, of course, is that I described a lot of stressors at the policy level. I described some of the general ones. I think it's important to recognize that within healthcare, we've been doing, we are a source of stress as well. So this is a great report from the Center for American Progress that highlights a number of particular events and traumatic events that led to some sort of policy change. This one relates to Tyra Hunter, a trans woman of color who died at the scene of a car accident because the EMT folks, when recognizing her as trans, left her. And here there's quite a disgusting statement that was found as it relates to the scene. And even when she was eventually brought to the hospital for possible resuscitation, she was neglected there. It led to a number of trainings and policies to address what was happening for the EMT within that region, as well as the hospital system that neglected Tyra. We also know that this is still happening across the U.S. This was a pediatrician in Michigan who actually refused to care for the child of a lesbian parents, and they're actually protected by the policies that govern our profession. And then again, of course, we know that this is coming up from HHS, where there is this notion that no one should be forced to choose between helping sick people and living by one's deepest moral or religious convictions. I always argue that if you have deep moral or religious convictions against helping sick people, you're probably in the wrong profession. But the problem here is this is a policy cover now for potentially discriminatory behavior, turning people away for needed preventive health care or even emergent care. It's quite disconcerting. And we've talked about this as this rule has come through recently from the HHS as it relates to eliminating protections for trans individuals. So I'm going to give a whirlwind, another whirlwind, as it were, overview of what are some of the state level policies that are really affecting or specific to LGBTQ folks. This is the general map. I apologize to my colleagues in Texas. You guys are in the danger zone. As it were, to potentially positive or the lack of positive and the presence of negative policies that are specific to sexual orientation, gender identity. I think some of the ones I will highlight are specific to access, ability to update documents, and then protections for youth as well. So here, this is the overall map, tallying everything up. And major categories that are included in this map, I just want to point out, are essentially protections or not as they relate to relationships and parental recognition, non-discrimination in general, religious exemptions as it relates to discrimination, protections for LGBTQ youth, healthcare access, issues as it relates to the criminal justice system within these states, and then of course, as I mentioned last, the identity documents, ability to change those and what is required to do that. So we'll cover some of those just to be mindful of time. So here, this is private insurance coverage for trans-related care. So does the state mandate that any insurance company operating within its borders provide protections as it relates to sexual orientation or gender identity? You can see a handful of states do that. So 13 states, DC and Puerto Rico do provide this kind of coverage currently. It is moving state by state. It is disappointing that while many insurance companies cross state borders, their policies, they do not automatically update them if one of the states that they operate in happens to provide this protection. There are, of course, there are potential for exclusions. So this is as it relates to Medicaid. So again, similar states that provide coverage or protection from discrimination from private insurance provide protection for discrimination from Medicaid, but there are a handful of states here, 10 states, that actually explicitly exclude gender-affirming care as part of Medicaid. And not surprisingly, us in Boston, we've actually seen a number of people move from one state that was not supportive to our state to access an insurance coverage that actually provided access to gender-affirming care. So this has been a bit of an issue. And this map, of course, is always changing, and it's a matter of keeping an eye on that in your own locality. And then, of course, state employees. So states are often some of the largest employers within their jurisdictions. The state-run insurances also have either protections and inclusions or explicit denials of coverage as it relates to gender-affirming care. And basics of employee non-discrimination. This is what the map looked like earlier, and this is what it looks like now. Thankfully, because of the recent Supreme Court decision, we know that employers are not allowed to discriminate based on a broad definition of sex and sex characteristics, and has been defined to include sexual orientation, gender identity, and expression as it relates to that as well. So this is the current law of the land. How this is going to play out moving forward is definitely a concern, especially with the current ongoing debate about the composition of the Supreme Court, as it has 8 seats out of 9 right now. We are cautious about if any additional case as it relates to discrimination were to work its way up to a new court, if this would still hold. For trans folks, updating gender markers and gender identity is a critical part of transition and critical part of people being able to affirm themselves. Not necessarily something everybody wants to go through or needs to go through, but for those who do, there are a number of hoops they have to jump through. Sometimes the state has very explicit requirements for publishing the name change in the newspaper or in a public document. Some states previously had required that they had to have a signed letter from a doctor saying that they had gone through specific surgical procedures, when we know for a fact that not all trans individuals want to or desire those kind of surgical procedures. Thankfully, that kind of law has moved away, but it still has been an issue within some jurisdictions, and similar to updating birth certificates. So whether the state even allows you to update that document. Thankfully, even under the current state department, the ability to update gender markers on passports is often much easier than being able to update it at the state level. So a lot of people are just using passports. So that's something to keep in mind as well. In terms of protections for youth or for students, these are the state laws and regulations that really kind of affirm non-discrimination specific to LGBTQ folks. So the magenta are states with non-discrimination laws that explicitly prohibit discrimination against students on the basis of sexual orientation, gender identity, and there are some specific agency guidance as it relates to transgender individuals, non-binary folks, and gender non-conforming students. As you can see, a large number of states without any laws prohibiting discrimination against students based on both sexual orientation or gender identity. This again recognizes kind of an opportunity for us to do better and perhaps influence that. And then here are essentially states that ensure that that public curricula address LGBTQ communities in some way, in a positive and affirming manner. And then the light blue states are the states that actually explicitly will not allow that. They are posited as no promo homo laws, essentially no promotion of the homosexual agenda is what they describe it as. So again, opportunities for improving at the local, at the state level. And then more specific to bullying, since we know that, as I described the issue as it relates to interpersonal interactions, those kind of stressors and discrimination and events can lead to worse downstream effects. And we have seen that for as it relates to youth, more specifically in a number of studies. The question is, how are we protecting youth then with bullying regulations and bullying laws? Some states very explicitly have enumerated anti-bullying and harassment as it relates to sexual orientation and gender identity. So these are the yellow states, which are increasing, which is great. But then the magenta ones are states that prohibit the school districts from having anti-bullying and harassment policies that specifically protect students on the basis of sexual orientation or gender identity. So these states are saying you absolutely cannot include these components into your anti-discrimination. So the state, again, intervening, saying we're not going to, not only are you not allowed to protect them, or that we're going to be explicit about protecting them, you absolutely cannot even say that you intend to. I focused a lot at this point on the US. I think it's important to recognize that despite us not being able to travel as much right now, this is a global issue. And the US has lagged for a long time, but that there are other players out there across the globe. And this has even come up when I've traveled or done work or to conferences about where am I going to be safe? I actually, when I was supposed to give a talk in Moscow for their medical association, I was forbidden from going for fear because that was shortly after they had passed their own laws as it relates to propaganda around sexual orientation. Thankfully, this map is slowly turning shades of blue. Over time, there's been a larger movement on the global scene to really improve the rights of LGBTQ individuals. It's come up in the UN on a number of occasions. But at the end of the day, it's more what's happening on the ground. So what kind of grassroots work is actually happening. And while we do our best to try and support that, we also need to recognize that it's not our job to come in and tell people what to do. It's our job to offer support when requested or when needed. And to really make sure that a lot of this growth is locally derived. So here at the bottom of this, and you'll be able to, again, have my slides, you'll see the issues in terms of moving from protections to explicit harm as it relates to here, specifically around same-sex sexual acts and attraction. So you still see a number of countries that have the death penalty or some sort of significant term in prison, all the way over to the other side in terms of providing explicit protections. Just south of us, Mexico has protections ingrained in their constitution that include sexual orientation. So opportunities for us even to improve. So I want to identify some opportunities for how to improve some of these policies. I've highlighted a lot of the different issues across states. Again, very 30,000-foot view of it. But highlighting that these are some specific ones that are being monitored, that we are associating with significant health, differences in health outcomes or even access to insurance and healthcare professionals. I think the big one, of course, is getting out there and voting. So really kind of choosing who is going to help you craft these policies, who actually controls the lever of power within your jurisdiction, and how supportive explicitly are they of LGBTQ issues. The other thing I like to highlight is my own personal bias as a researcher, is that we do need better data out there, and that we need to make sure that across different jurisdictions that we're actually collecting information to understand what are the effects of policies of stigma on LGBTQ individuals. A lot of the data I had shown earlier used national surveys like the Behavioral Risk Factor Surveillance System, which, while it has questions to identify sexual orientation and gender identity, that question is optional and has never been used by every state in the same year. And some states have used it and then stopped using it because they did not like asking the question because it was revealing some issues as it relates to disparities within their own borders. Some people said they didn't have the money. The CDC has turned around and said, we will give you the money if you want to do it. Nobody answers their phone calls after that, apparently. So I always make a big push for better research that really collects information for us to better understand what's going on. Again, vote. I want to make sure that people are recognizing the opportunity to not only vote in large national elections like the one that's coming up in less than 2 weeks, but also to vote within their municipalities. Long before a lot of states even had protections as it related to gender identity for anti-bullying, school districts were able to regulate that and determine what was going on. So again, recognizing that there are multiple levels to affect policy that actually are going to impact the well-being of your communities. So kind of recognizing school districts, school boards as an opportunity to intervene for the sake of youth, recognizing your own city and essentially the power of mayors to provide protections within their jurisdictions. A lot of cities were ahead of the curve on a number of LGBTQ anti-discrimination issues, so recognizing that those elections need to happen. And again, pushing more on the issue of data collection. While I was talking more about public health and such, this also needs to be done clinically. We need to better understand what's going on within our own clinics, and are we asking questions appropriately of our patients, especially of youth patients? Are we asking questions that allow people to feel comfortable, and are we creating environments that are allowing people to feel comfortable? So while I could give you a laundry list of all the different policies that really need to be updated, I think it's really helpful to just think of it at all the different levels and all the different interactions that our patients have, what needs to change. We need to make sure that our institution has, our hospital or healthcare system has non-discrimination explicitly inclusive of sexual orientation, gender identity. We need to make sure that the actual physical space is inclusive, so making sure that there are gender-neutral bathrooms for folks. We need to make sure that intake forms are collecting information in a non-gendered manner or a non-strictly binary manner. Anytime there's questions about parents, it's not going to be asking about mom and dad, it should be asking parent or guardian. If you're asking about spouse, it should be spouse, not asking about husband or wife. And these are structured things that can be done on forms and on our intakes to really signal to folks that we are trying to create a more inclusive environment. And honestly, as an individual and having done this work for a long time, I will tell you, everybody is looking for these cues when they go to these kind of, go to seek a healthcare professional's care. We are looking for any little signal that we can be safe and open and out there. And these are things that can be done in multiple different environments, not just within the healthcare system, but again, within schools for youth as well. And then to kind of belabor the point is voting is really important. I cannot stress this enough because while voting at every level has the opportunity to create change and has the opportunity to really give you the opportunity to make sure that LGBTQ folks are being heard. And then of course on the flip side, and I don't have a slide for this, is think about running yourself or getting in a position where you can actually affect policies. I spent a few years on the AMA's Committee on LGBTQ Issues because that was their main advising and policy arm as it related to sexual orientation, gender identity. We passed a slew of policies within the AMA to address gender marker change, to address insurance access, to address conversion therapy bans and such. And this then, by changing these policies within this organization, requires the AMA to then go out and lobby on behalf of that policy. And it has been a significant benefit in terms of being able to have the AMA show up to a congressman and say, we as a voice of a large block of physicians believe that this is what needs to happen. And same thing can happen in all of our specialty societies as well. So as I mentioned, I'm a fast talker. I have already finished up my slides, but I know we have probably a lot of questions. I saw questions popping up, but I couldn't see them all. But I want to take this time to have a drink of water and pause and let people think if they have questions.
Thank you so much, Dr. Streed. That was an absolute wealth of information. And while you're taking a little bit of a break, I'm going to invite anybody to unmute themselves and ask a question themselves. While we're waiting on people to speak up, I'll just summarize what came through in the chat. Aurelia, I see you've unmuted yourself. Did you want to ask a question?
Yes, I did, but I can wait for your summary.
Oh, no, you can go ahead.
I wanted to ask about the data collection, TransPop, I believe. If you could say a little bit more about that.
Yeah, so TransPop is, so again, run by the folks from UCLA, the Williams Institute, and others, and collaborating researchers across the US. They're essentially doing a probability sample. So their goal is to try and create a data set that is representative of trans individuals across the life course within the US. They have preliminary data right now. We're actually working on publishing something as it relates to cardiovascular differences, risk and outcome differences across gender identities. That data will be open to outside researchers in the next few months, I believe. But the folks at the Williams Institute, Jody Herman and Elian Meyer, would be the main folks to reach out to about that. But they had presented that they were closing. They had presented that they were closing their data collection last year at the U.S. Professional Association for Transgender Health, if I remember correctly. But yes, so it's ideally going to be a fairly good representation of the U.S. trans population, adult population.
Thank you.
Okay, and then Yona, did you want to maybe ask your question? And then I'd like you to also maybe just for all of the participants and for Dr. Streed, let people know about this generations team and the generation study as well.
Yes, it's a broad team I'm seeing.
Sure. Yeah. So, thank you for your talk, Dr. Streed. It's been very informative and very illuminating. I think in Texas, we're noticing a lot of the adverse effects that policy has on queer folks. And as someone who is self-identified trans and queer, I am experiencing that and have experienced a lot of those things in regards to navigating policy and the government. Just in the last state legislative session, there were a multitude of laws that were granting religious freedoms to essentially discriminate and prevent queer folks and associates of queer folks to getting the care that they need, and really providing protections for people of different professions to really exercise their quote religious freedoms in order to discriminate against at-risk and minority populations. So I really thank you for addressing that. You had mentioned generations data, and I just wanted to let folks know who are listening in that a good portion of the generations team actually is based at UT, led by Dr. Stephen Russell, who is the, I believe, department chair for Department of Ecology. But the Sexual Orientation and Gender Identity Health and Research Lab, which is in the Human Development and Family Sciences Department, has been working a lot on that. So there's a great group of graduate students, doctoral students, people who have already graduated, and undergrads who've been working on that data and that work. So there's a lot of SGM research going on, even in a very very conservative place such as Texas. And then my question to you would be, can you talk more about how positive research that affects mostly on the positive aspects of sexual and gender minority health and wellness may mitigate the effects of minority stress theory?
Absolutely. So one, thanks for pointing out the team for the generations. It is again across the country, which is awesome. And you're right, the UT folks are a large part of that. I would also point out, I think somebody else put this into the chat, that Dr. Russell and again a team of national experts have recently released the National Academy's new statement on understanding the status and well-being of LGBTQIA folks. Literally, that was the talk right before this one that I was listening in on. And I think it looks like Wesley Hartman has dropped in the link for that. So just so folks know, there's much more there. It's also referencing a lot of the generations work as well. So I'm glad you guys are doing that. And it makes me think too that to not stereotype where people are, where they're doing the work. Sometimes adversity breeds significant creativity and productivity. And I feel like the generations team at UT is an example of that. To your question, so there has been this has become a growing critique and a movement as it relates to LGBTQ, or generally research that focuses on minoritized groups, is what's going on the other side. There are people who are thriving, so how do we better understand that? I think there are a few studies that I'd like to highlight as it relates to this. One is the Family Acceptance Project with Caitlin Ryan, who's been doing this for as long as I can remember. I think the first time I heard about their work was I was a medical student not too long ago. But essentially highlighting how family acceptance and or rejection affects certain youth outcomes. So the positive here is that they note that family acceptance, through their different measures of that, the more accepting a family is of their youth, regardless of their sexual orientation or gender identity, or being supported very specifically as it relates to those identities, leads to a higher likelihood that the youth can report thinking in a future-oriented manner. So instead of having to be so worried about surviving in this moment or navigating potential negative effects at home, people are in a supportive environment to where they can then think about the future. They can actually then imagine themselves as a happy, productive adult. The flip side, there's always the flip side to all of this, of course, is that more rejection leads to issues as it relates to hypervigilance, issues as it relates to poor coping mechanisms such as substance use and the like, and of course, depression and suicidality. The flip, as I want to reiterate, is again, acceptance leads to better outcomes and a future-oriented perspective. There's been more work done looking at some work that I had done with Dr. Nikki Eliason, looking at resilience within LGBTQ identified healthcare professionals. And we found that higher resilience kind of predicted that people were actually going to be at environments that had fewer protections. And our hypothesis that we're still exploring is it might be that people with higher resilience or ability to bounce back from negative issues are the ones who are kind of at the front line trying to really make change happen. So I think that's kind of where we're looking at. There is still a dearth of this kind of positive focus, this thrive. I would describe it as like research that looks at thriving. There's much more out there that I can't recall off the top of my head, but I would point out there's a lot of data sets that are including measures of this. One I would always like to highlight is the PRIDE study, which is a patient-centered outcomes research institute, the Corey-funded study, now based out of Stanford, that has multiple years of nearly 20,000 LGBTQ individuals filling out extensive surveys, very in-depth surveys, and they do have measures as it relates to thriving and resilience that I think, and again, that's actually open to outside researchers now as well. So I think there are multiple opportunities to expand on this to really look at other potential aspects of thriving in the face of adversity. Some of the other stuff I'm recalling now off the top of my head is looking at community engagement among trans folks in New York. I think that was associated with better sleep quality, if I remember correctly. That's work from Billy Caceres, who headed the AHA statement that I highlighted. And I'm trying to remember if there was if they also saw community support leading to lower prevalence of hypertension. I'm forgetting. But again, this is highlighting that this is an opportunity to really expand in this area as well. And yes, you will be hearing more from PRIDE this Friday. I'm looking through the chat. The chat has a whole bunch of resources, not a whole lot of questions, which I think is helpful. So there's a lot of links there for folks. I recommend taking a look at that. Any other questions from participants?
I have a question if nobody is chiming in, but participants feel free to interrupt and let me know if you have a question. But I thought it was really interesting, Dr. Streed, when you were talking about the different revisions that the DSM has been through. You mentioned something like, maybe in the next iteration, the DSM might get rid of this kind of pathologizing idea of even dysphoria. Yep. And I wonder how, if you could speculate on kind of how that would change a lot of the medical policies that we have in place that require, for instance, a provider themselves to diagnose somebody's own gender identity. Right. Which is a very strange exercise. I've done it myself, having to write a letter saying, yes, I, as a medical provider, believe that this person has a sense of their own identity. It's like a very kind of strange thing. So could you kind of talk about, what caused that shift, whether you think it's culture or policy or research, and how you might see that going forward?
So this is one of those harder things. Our healthcare system, many problems with our healthcare system. It's like shooting fish in a barrel. It's really easy to point out some of the major issues. I think one as it relates to this is the need to have a pathology for us to treat somebody. We have to have something on a problem list to address for us to even to provide treatment within our capitalist designed healthcare system. So for the main issue, one issue that we've talked about, even when we switched from disorder to dysphoria, was how were insurance policies going to accept this change? Was insurance going to cover the switch from disorder to dysphoria because it becomes less of a pathology? And this is actually one of the concerns as we move away from even gender dysphoria as a diagnosis, because all of our insurance, all of our policies are specific to diagnoses. We're still trying to navigate this, honestly, at this point. I'm not optimistic that it's going to be like a complete removal from the DSM. I think it will probably just call it something else and maybe put it in a section that isn't really about pathology, but really just about conditions. So as gender as a condition, and maybe we talk about gender for everyone that way, as opposed to just being a pathology or a pathological category as it relates to trans individuals. Because the thing to remember, of course, and any trans person could tell you this, and we know this across research, gender dysphoria is not an experience of all trans individuals. Like that's the truth of the matter. It is for some folks, not for everyone, but insurance requires us to put that diagnosis down for them to be able to have insurance cover any kind of gender affirming care. So it's a major frustration of the system. I know WPATH in their update of standards of care is really trying to expand on what it means for gender dysphoria to exist or not exist, to make sure that it also is more inclusive of non-binary identities, since even the folks in WPATH recognize that their standards of care are often quite binary in focus. There's questions, any studies on improvement of symptoms in trans folks after gender affirming care? Yes. So there's a number of studies, a lot of them by Siri Reisner, a slew of researchers from Northern Europe, where they've been doing gender affirming care longer than we have because they didn't shut down when we did, that generally quality of life improves and a number of anxiety related diagnoses do decrease. I think a lot of the critique that some opposed to trans rights say is that these treatments do not get everything back to zero, that trans people still have higher rates of suicidality and mental health conditions even after gender affirming care. I point out that the treatments improve it, and honestly, there's only so much we control. Society, I believe, honestly, society is the larger impetus for negative outcomes for minoritized groups, including trans individuals. So until society is treating everybody equally, I'm not going to buy anybody's argument that this affirming care isn't doing enough. It's doing what we can in that moment, but recognizing that we as healthcare professionals should be advocating to change society as well.
Thank you. And yeah, I think we're going to try to, we are amassing a list of all of the different publications and primary sources that have come up in these different talks.
Yep.
Shout out to Yona for doing that. She's been collecting a lot of it.
Thank you, Yona.
And so I think we're near the end of time. If there's not any more questions, I just want to thank you once again. And I think this was just really helpful to remind us of the power of research to be able to move policy in the direction of health and wellness and to kind of use it as a lever for change. So thanks again. And I will email everybody here once the recording of this is up, and hopefully we can work with you in the future. Dr. Streed, thanks for being here.
For sure. And thanks for putting this together and for being really quick about making this virtual. And I've really enjoyed ducking in and listening to the presentations I can.
Thank you. Thanks, everybody.
Have a good day, everybody.